Welcome to Unit 6 of our IV therapy course. In Unit 6, we will be discussing additional procedures related to the LPN and IV therapy and antibiotic administration. Please refer to the reading assignments and course syllabus for additional information. The objectives for Unit 6 include list additional IV therapy procedures that an authorized LPN is permitted to perform, outline the steps of specified IV therapy procedures, discuss the advantages and disadvantages of IV medication administration, discuss antibiotics in terms of purpose, action, dosage, contraindications, untoward effects, interaction and compatibility issues, therapeutic effects, and nursing considerations. Describe when it is appropriate to stop blood or blood products. Utilize proper protocol to prepare and administer an IV piggyback containing an antibiotic additive. Identify nursing observations and actions relative to IV antibiotic administration. In this unit, we will cover the following specified allowed procedures for the qualified LPN. 1. Hanging IV infusions. 2. Adding IV solutions to existing infusions, maintaining infusions. 3. Allowable solutions to be administered by the LPN through a central line. 4. Changing IV site dressings, peripheral. 5. Changing IV site dressings, central line. 6. Changing a midline dressing and discontinuation. 7. Changing IV tubing, peripherally. 8. Inserting an over-the-needle catheter. 9. Converting to intermittent infusion devices and HEPLOCs. 10. Flushing intermittent infusion devices and maintaining patency. 11. Reconstituting an antibiotic additive. 12. Administering an IV antibiotic via piggyback. 13. Stopping blood or blood components. And 14. Other authorized procedures. Although we have already discussed hanging IV fluids in connection with initiating IV therapy, there are other times during the infusion therapy that hanging IV fluid also can occur. The same steps you use to prime the tubing that we discussed in this last unit are used when it is time for a tubing change. In addition, if the patient's IV site has a saline lock and no fluids have been infusing, the saline lock will need to be flushed prior to hanging new IV fluids. Remember, if fluids, flushes, or medications are being administered through a central line, placement must be confirmed with a chest x-ray prior to the first use of the central line. The procedure for hanging IV fluids includes remove the IV bag from the protective cover and make sure you're checking the expiration date and assessing for cloudiness or leaks. Hang the IV bag on a pole. Remove IV tubing from its bag. Ensure that the roller clamp is closed. Spike the bag. Fill the drip chamber half full. Open the roller clamp and prime the tubing. Close the roller clamp and replace the protective cap. Label the tubing with date to be changed. Adjust roller clamp to appropriate drip rate or place into IV pump and set rate. When an IV is to remain in place with fluids continuing to infuse, another container of solution must be hung before the last solution container runs dry. The new solution is usually hung when the solution that is infusing reaches about 50 milliliters remaining. First, determine which solution is required next according to the orders. It is very important to check the physician orders as the type of solution could have changed throughout the infusion therapy. Next, wash your hands and select the correct solution and inspect it for cloudiness, particles, and any other signs of contamination. A contaminated solution must not be used. Make sure that the tubing does not also need to be changed at this time, and you'll verify that with your organization's policy. If so, you will also need to gather the supplies for a tubing change. When you're in the patient's bedside, you properly identify the patient. Inspect the IV site for signs of complications. If the IV site shows signs of infection or infiltration, the site should be changed before the new solution is added. Hang the IV container on the IV pole. Remove the container that is almost empty, crimp the tubing close to the drip chamber or close the roller clamp, and remove the spike from the used container. The tubing must be occluded while you change IV containers to prevent air from entering the tubing. Keep the spike from being contaminated. If the spike becomes contaminated, new tubing must be obtained. Remove the cover from the IV tubing port on the new container and insert the tubing spike into the new container. Check for any air bubbles in the tubing. Check the flow rate and make sure it is flowing according to the prescribed rates. Add a time strip to the bag if this is a gravity infusion, or if an electric infusion device is being used, program it with a new volume to be infused. Finally, dispose of the empty container after removing and destroying any labels that include the patient's name, and make sure you document the added fluid on the IV flow sheet or MAR so that I's and O's and appropriate documentation is maintained. Remember as we continue through this unit that the qualified LPN is only allowed to operate within his or her scope of practice and is limited to the solutions discussed in Unit 1 as allowed by law and rule. The only medications that the LPN is allowed to administer other than these fluids listed here are IV piggyback antibiotics. When vitamins and or electrolytes such as potassium are administered, they must be dissolved in one of the allowed fluids, and the RN must initiate the infusion. The LPN is only allowed to hang subsequent containers of these solutions. The solutions that we are allowed to hang are 0.9% sodium chloride or normal saline or abbreviated NS, 0.45% normal saline, which is also abbreviated half normal saline, 0.33% normal saline, 0.2% normal saline, lactated ringers, abbreviated LR, dextrose 5% is abbreviated D5W, sterile water, or combinations of the above. LPNs can hang antibiotics, and as stated previously, if vitamins or electrolytes are being administered, they must be dissolved in one of the solutions listed above, and the RN must hang the first bag. Peripheral IV dressings only need to be changed when visibly soiled, contaminated, or if the dressing is no longer intact. Reinforcing the dressing with tape may prevent the ability to monitor the IV site. Prior to beginning the procedure, be sure to check for any allergies such as to latex or iodine. Wash your hands and gather your supplies. You will need gloves, skin cleanser, Tegaderm, a saline flush, and possibly tape or securement device. Explain the procedure to the patient. Always stabilize the cannula during this procedure in order to prevent inadvertent displacement of the cannula. It is important to prevent contamination of the IV site and also to prevent dislodging the cannula during the dressing change. After donning the gloves, carefully remove the Tegaderm while stabilizing the cannula with your other hand. Assess if the strips of tape securing the cannula or other type of securement device need to be changed due to soiling. If the tape strips or other securement device needs to be changed, have the new tape or device ready before removing the old. Any dry blood needs to be removed. If possible, change gloves prior to cleaning the site. Next, clean the site thoroughly for a full 30 seconds and allow to dry completely before applying the new Tegaderm. After applying the new Tegaderm, perform a flush, making sure that the IV site is still patent after the dressing change. Be sure to reapply a label to the site. Your label should now indicate not only the dressing change, but also the data that the IV was originally initiated. Central line dressings are normally changed weekly, or if the dressing becomes soiled, contaminated, or is no longer intact. Be sure to follow your facility policy for central line dressing. Although law and rule allows a qualified LPN to change a central line dressing, some facilities still require a registered nurse to perform these dressing changes. Be careful during this procedure not to contaminate the IV site or to dislodge the catheter, especially with PICC lines. First, read the physician's orders to verify the order written for a dressing change or follow facility policy. Gather all equipment prior to beginning the procedure and wash hands. In addition to a CVC kit, you will also need extra clean gloves, an extra mask, and hand sanitizer so you do not have to leave the bedside to perform hand hygiene. If your facility uses a device such as a biopatch, you will need a new biopatch with each dressing change. If you are changing a dressing for a PICC line, you will also need alcohol pads, skin prep, a new securement device, and a measuring tape. Be sure to identify the patient, explain the procedure, provide privacy, and position the patient. Using a clean surface, open the CVC kit and apply a mask to both yourself and the patient. Prepare the rest of the CVC kit in a sterile manner. If the patient cannot tolerate wearing a mask, have the patient turn his or her head to the opposite side. Don clean gloves and carefully remove the old dressing in the direction of the catheter was inserted. Note any drainage, appearance of catheter and skin at and surrounding the insertion site. Be careful not to touch the insertion site or the hub of the catheter. If you are changing a dressing for a PICC, the securement device also needs to be changed. Loosen the device with alcohol pads and remove, being extremely careful not to dislodge or change the position of the catheter. Remove gloves and dispose. Perform hand hygiene. Do not lose sight of the catheter insertion site. Next, apply sterile gloves. Clean the site thoroughly using the ChloraPrep or other cleanser provided in the kit. Use repeated back and forth strokes of the sponge to clean the site. During cleaning, stabilize the catheter with a non-dominant hand. This hand now becomes contaminated, and this hand cannot touch any area of the skin, hub, or lines that will be covered by the dressing. Clean for approximately 30 seconds. Allow site to completely dry before proceeding. If the dressing changes for a PICC line, apply skin prep, allow to dry, then apply the new securement device. Apply a new biopatch if required by your facility policy. Apply sterile dressing with sterile technique. If the dressing changes for a PICC, you will need to measure with a measuring tape from the insertion site to the hub to make sure that the catheter location has not changed. Finish up by removing your gloves, removing the mask, performing hand hygiene, and documenting the procedure. Be sure to label the site. Some facilities require that the caps or saline locks be changed at the time of the dressing change. If this is the case for your facility, know that this step must be done by the registered nurse. Keep in mind with central lines when you're flushing, make sure you're using clamps. As you will recall from Unit 3, a midline catheter is a long peripheral IV that is placed in a peripheral vein, generally inserted near the antecubital fossa, and the tip ending below the axilla. These catheters are generally between 3 and 8 inches long and are used when therapy is anticipated to last from 1 to 4 weeks. Stabilization devices used for midline can vary. Use the techniques discussed for PICC line dressing that we previously discussed in order to change a midline dressing. There is a sample policy and procedure listed in the handouts for this unit that you can also refer to. When it comes time to change the tubing, remember that the qualified LPN can only change tubing on peripheral IVs. The registered nurse must perform the tubing change on central lines. Under current law and rule, LPNs are prohibited from changing tubing or any device on an arterial catheter and tubing that is directly connected to a central venous catheter or any catheter line that does not terminate in a peripheral line. It is important to prevent contamination and to prevent air from entering the IV system during a tubing change in order to avoid the potential complications of infection or air embolism as a result of this procedure. Continuous tubing or tubing that is continuously connected to the patient's IV site with some type of fluid continuously flowing needs to be changed every 72 to 96 hours. This tubing should be changed at the time the IV site is changed. Whenever an IV site is changed, new tubing should be used. Never move old tubing over to a new IV site. Intermittent tubing, or tubing used for fluids or antibiotics that is not continuously connected to the patient and running, needs to be changed every 24 hours. If there are any add-ons being used with the tubing, such as a secondary line, extension sets, filters, etc., these add-ons must also be changed every time the tubing is changed. It is best to try to coordinate the tubing change to occur at the time a new bag is being hung so that the new tubing is not inserted into a bag that has been hanging for several hours. No bag should be allowed to hang more than 24 hours. If you are able to time the tubing change for the time when a new bag is to be hung, the procedure is the same as discussed earlier for spiking bag and priming the line. Always be sure there are no air bubbles prior to attaching the new tubing to the patient. If the new tubing is being attached to a saline lock or other intermittent infusion device, be sure to clean the device thoroughly with alcohol before attaching the new tubing. Next, we will explain the procedure for converting to intermittent infusion devices. Remember that intermittent infusion devices may also be referred to as saline locks, heparin locks, HEP locks, or PRN devices. It is currently only within the qualified LPN scope of practice to perform this procedure for peripheral IVs. In some facilities, when the IV is initiated, a saline lock is not immediately used. Therefore, the tubing may be connected directly to the hub of the IV cannula. In such cases, the tubing cannot be removed without immediately attaching a saline lock or intermittent infusion device. If the tubing were to be removed, the cannula would bleed, and microorganisms could directly enter the bloodstream. A properly used intermittent infusion device prevents both of these complications. First, as always, check your physician's orders and facility policy. Next, wash your hands and prepare your equipment. You will need the intermittent infusion device, a flush, a sterile 2x2 gauze pad, gloves, alcohol tape, and a cap for the tubing. Identify the patient, wash your hands, and explain the procedure. Stop the infusion and clamp the tubing. Prime the intermittent infusion device with the saline flush and leave the flush attached. Don gloves. Place the sterile gauze under the connection where the tubing is connected to the hub. Apply gentle pressure to the vein above the cannula site and remove the tubing, holding the end of the tubing in such a way that the tip does not become contaminated. Immediately remove the cap from the saline lock and insert it into the hub, twisting until secure. Flush the IV site with saline, monitoring for infiltration or other complications. Apply the extra cap to the tubing. Calculate when the tubing needs to be changed and relabel the tubing accordingly. Secure the saline lock with a piece of tape across the top. Clean any blood with the alcohol wipe. LPNs may not change an intermittent infusion device that is connected to a catheter that terminates in a central vein. Intermittent infusion devices must be flushed every 8 hours at minimum, and before and after any medication administration or lab draws. Most devices are now flushed with saline according to your facility policy. However, heparin may still be used as a flush under two conditions. First, there must be a specific order from the physician, and second, your facility must have a policy for this type of flush. Flushes are done with 10 milliliter syringes. Since syringes smaller than 10 milliliters have a greater PSI or force and can possibly rupture a cannula. So even if your facility only requires 3 mils of flush, you should still use a 10 milliliter syringe. Saline flushes are effective, less costly than heparin, and involve less steps than heparin. Use of heparin involves extra steps and extra cost, possibility of allergic reaction, and possible increase in clotting times if an incorrect dose is given. Many facilities stock various strengths of heparin, so the possibility of a life-threatening dosage error can exist with heparin. Flushing peripheral intermittent infusion devices is done to ensure and maintain patency, to prevent mixing of meds, and when converting from continuous to intermittent therapy. Potential complications include contamination, infiltration, phlebitis, and air embolism. The nurse must use aseptic technique and monitor carefully to prevent complications. To begin, again, verify the physician's order and the facility policy. Next, wash your hands and prepare your equipment, which includes the flushing solution and alcohol wipes. Identify the patient and explain the procedure. Clean the intermittent infusion device with alcohol for at least 30 seconds, making sure to clean with twisting motion to thoroughly clean the threads. Remove any air from the flushing syringe and aseptically attach the syringe to the intermittent infusion device. Some sources recommend general aspiration at this point. Aspiration involves pulling back slightly on the plunger until blood is seen entering the cannula. Aspiration is not a reliable indicator of patency because if blood is not seen, this in itself is not evidence that IV site is no longer patent. In addition, if the blood enters the intermittent infusion device, the device becomes contaminated and must be changed. Next, slowly flush the required amount of solution. Facility policies vary. However, a flush between 3 and 5 milliliters is typical. As you flush, carefully monitor the IV site to make sure there is no leaking, swelling, redness, or patient complaints of pain. When the flush is complete, continue pressure of the plunger as you disconnect the syringe from the flush. If you meet resistance during flushing, do not force the flush. Make sure your syringe is securely attached to the intermittent infusion device and make sure that there is no possible kink in the cannula due to positioning. Attempt the flush again. If you still meet resistance, discontinue the procedure. The IV must be restarted in another site. Flushing central intermittent infusion devices is done to ensure and maintain patency, to prevent mixing of meds before and after medication administration and blood draws, and when converting from continuous to intermittent therapy. Potential complications include contamination, infiltration, phlebitis, and air embolism. The nurse must use aseptic technique and monitor carefully to prevent complications. To begin, verify the physician's order and the facility policy. Next, wash your hands and prepare your equipment, which includes the flushing solution, gloves, and alcohol wipes. Syringes must be 10 milliliters. If the central line has more than one line, such as a triple lumen, you will need a separate syringe and alcohol for each lumen. Identify the patient and explain the procedure. Don the gloves and clean the first intermittent infusion device with alcohol for a minimum of 30 seconds, making sure to clean with a twisting motion to thoroughly clean the threads. Alternatively, if an alcohol cap is being used, as long as the cap has been in place at least 5 minutes, you will not have to clean with an alcohol pad. Remove any air from the flushing syringe and aseptically attach the syringe to the intermittent infusion device. Aspiration to confirm patency by pulling back slightly on the plunger until blood is seen entering the line. Do not allow blood to enter the intermittent infusion device, as this will contaminate the device and require it to be changed. Remember, that is not within your scope of practice to change intermittent infusion devices on a central line at this time. Next, slowly flush the required amount of solution. Use a turbulent flushing pulse technique or start-stop technique. As you flush carefully, monitor the IV site to make sure there is no leaking, swelling, redness, sudden increase in heart rate, or patient complaints of sudden shortness of breath or chest pain. When the flush is complete, continue pressure on the plunger as you disconnect the syringe from the flush. Apply a new alcohol cap if required by your facility. If you meet resistance during flushing, do not force the flush. Make sure your syringe is securely attached to the intermittent infusion device and make sure that there is no possible kink in the cannula due to positioning. Attempt the flush again. If you still meet resistance, discontinue the procedure and notify the RN or healthcare provider immediately. If there are additional lines to be flushed, use a new syringe and alcohol pod for each line. The frequency of flushes for central lines may vary according to the device being used. Hickman, Broviac, and chest ports all have different requirements for additional flushes when the catheters are not being routinely used. Be sure to check your facility policy and the physician's orders. When a heparin flush is ordered, your facility policy will likely be similar to the example noted on this slide. The acronym SASH is useful for remembering the steps in the procedure. First, flush the device with normal saline, 10 milliliters. Next, administer the medication such as the piggyback antibiotic. When the antibiotic has completed, flush the device again with another 10 milliliters of normal saline. Then follow with a flush of 2 milliliters of heparin. Be sure you have the correct concentration of heparin for this flush. The CDC recommends heparin flush only when the device is used for blood sampling. Next, we will discuss IV antibiotics. There are many advantages to the administration of antibiotics via IV compared to oral and other routes. IV administration provides direct access to the circulation system with the hepatic first pass effect. The need for dissolution and absorption is eliminated. IV administration provides a route of administration of fluids and medications to patients who cannot tolerate oral medications for a variety of reasons. Instant drug reaction is achieved. However, there are also disadvantages to IV antibiotics. Disadvantages include costs, the potential for drug interaction because of incompatibilities, potential for leaching, and increased risk of complications such as speed shock, extravasation, and phlebitis. We will discuss all of these potential complications in the next unit. In addition, any medication errors have an instantaneous effect and can be more profound and serious than an oral medication error, as there is no way to retrieve the medication or stop its action once administered via IV. The general nursing responsibilities for IV administration of antibiotics are essentially the same as what is required of a nurse when administering a medication through any other route. The nurse must be knowledgeable of the medication ordered, including its action, normal dosage rates, side effects, interactions, or compatibilities, and why this particular patient is receiving this medication. The nurse needs to know if the prescribed route is appropriate, must use aseptic technique and standard precautions. The nurse should verify that the medication has not passed its expiration date and must follow the manufacturer's guidelines for disposal and storage. The nurse monitors the patient not only for therapeutic response to the medication, but also for any adverse effects, including life-threatening ones. The nurse is responsible to clarify any unclear or unsafe orders with the healthcare provider. Let's review the INS standard related to antibiotic additives. Nurses are responsible for assessing the appropriateness of prescribed therapy, including patient assessment, patient age and condition, appropriateness of solution and medication prescribed, and appropriateness of drug and its dose, route, and rate. Before administration of the solution or medication, the nurse must be knowledgeable in indications, actions, use, side effects, and adverse reactions associated with the solution or medication. Administering IV antibiotics requires that the LPN be familiar with general principles of antibiotic therapy. The LPN needs to know the type of antibiotic being administered, its classification and therapeutic action, normal dosages, contraindications, and side effects. In addition, the nurse needs to research possible interactions and compatibility issues prior to administration. In your handout, you will see this chart which reviews types of antibiotics and a brief summary of the action, uses, and other pertinent information. This chart is meant for review purposes only and is not intended to replace careful research in a current nursing drug book or other resource, or per your facility's policy. In acute care facilities, the pharmacy often reconstitutes the antibiotics and sends it to the floor already. However, in some long-term care and home health care settings, the nurse must reconstitute the antibiotic prior to administration to the patient. This is allowed by law and rule in the case of antibiotics for the qualified licensed practical nurse. After verifying that you have the right medication, the right dose, the right time, the right patient, and the right route, you also need to verify expiration dates of both the medication vial and the diluent vial. Step 1. Reconstitute the medication using the label and package insert. Be sure to use the correct type and amount of diluent solution as indicated by the manufacturer. Common diluents include normal saline, sterile water, or D5W. Some liquid meds may require dilution even if you don't reconstitute. For example, if you received an order for aloxetin as noted on this slide, you would need to refer to the package insert for the initial reconstitution instructions. You would draw up 10 milliliters of either sterile water or 5% dextrose as directed and inject the diluent into the vial. Remove the needle and gently roll the bottle to mix it well. Sometimes it takes several minutes for the powder to completely dissolve. Do not continue until the powder is completely dissolved. If this is a multi-use vial, immediately label the vial with the date, time, and diluent used to reconstitute. Be sure to read the package insert to see how long the medication is good for after reconstitution. Step 2. Calculate the amount to administer and draw up into a syringe. Make sure to use a syringe large enough for the entire dose. Label the remaining solution. We will continue with the example we started in step 1. You've already reconstituted and rolled this vial until the powder has been dissolved. To figure out the amount to draw up, use the ordered amount of 25 milligrams and 250 milliliters of D5W. You have on hand aloxetin 50 milligrams and 5 milligrams per mil. After you cross-multiply and divide, you would need the 5 milliliters of the reconstituted solution in order to administer the physician's order for a dose of 25 milligrams. Next, return to the label and physician's order to determine the size of the IV bag and the type of solution that this dose should be further diluted into. For example, now that you have drawn up the ordered dose of 25 milligrams or 5 milliliters, you return to the physician's order, which states to administer this dose in 250 mils of D5W. You can see from the package that this order is in harmony with the package instructions, which state that the further dilution required can be 250 to 500 milliliters of 5% dextrose. After obtaining the appropriate bag of solution, clean the injection port with alcohol. Insert the needle of the medication-filled syringe into the medication port and inject the drug. The needle should be 19 or 20 gauges and 1 inch long. Then remove the needle and invert the bag gently several times to thoroughly mix the medication with the solution. Always make sure you are using the correct solution, otherwise you may have a compatibility issue. Visually inspect the bag to make sure the solution is well mixed and there is no cloudiness or undissolved particles or leaks. Label the bag immediately. Also, don't add to a solution already infusing. There's a risk of altering the drug concentration. For example, in our scenario we have been working with, you've now drawn up the ordered dose of 25 milligrams or 5 milliliters. You will inject this dose into the ordered 250 milliliters of D5W. This will give you a total in the bag of 255 milliliters, which is the original 250 milliliters plus the 5 milliliters. Before heading to the patient's room, it is a good idea to calculate what the flow rate or drip rate will be. For this class, add the amount already in the bag to the amount added from the syringe to determine the rate and the total volume to be infused. Continuing with our scenario, you now have a labeled bag that contains 25 milligrams or 5 mils of Alexatin and 250 mils of D5W, which means the bag now has 255 milliliters. First, let's calculate the flow rate. The formula, as you recall, is F is equal to the volume over time. So we will divide the volume, which is 255 milliliters, over the time, which is 1.5 hours. This gives us a flow rate of 170 mils per hour. Next, we will calculate the drip rate. Using the formula milliliters per hour times the drop factor, we will get 170 times 15. And then we need to divide that by 60 to get it from hours to minutes. And the answer is 43 drops per minute. Now let's practice. How much and what type of diluent will you inject into the vial? How much will you draw up for one dose? Into what type and size of bag will you inject it? What will your flow rate be if you have a controller? What will your flow rate be if you don't have an electronic device? Go ahead and pause the presentation while you attempt this practice problem. When you have your answers, resume the presentation and proceed to the next slide. According to the instructions, you would reconstitute with 4.8 milliliters of sterile water. Next, you would calculate your dose on hand. You have 100 milligrams per mil and the order is 400 milligrams. The amount you should draw up for one dose should be 4 milliliters. According to the instructions, you will insert this 4 milliliters into a bag of 250 milliliters of normal saline. After injecting the medication, the bag will now contain 254 milliliters. To calculate the flow rate, you divide the 254 by 2 hours, which gives you a flow rate of 127 mils per hour. Finally, to calculate the drip rate, you take the 127 by 15, which was the drop factor, and divide that by 60 to get it into minutes, and that will give you 31.75, and we round to the nearest whole number, so that will give you 32 drops per minute. Whether you are administering an antibiotic that you just prepared by reconstitution or administering antibiotic prepared by pharmacy, there are several important nursing considerations you need to implement. Check and recheck the order at least 3 times with the drug label, as you do for all other medications. Be sure to check the expiration dates of the medication, the diluent, and the IV solution. Confirm that the drug manufacturer's recommended diluent was used to reconstitute the medication, if applicable, and what storage requirements there are for the medication. Make sure to check all labels to confirm IV use is listed on the label. Make sure solutions are well mixed with no cloudiness or floating particles. Make sure any ordered cultures are sent before starting antibiotics. Be sure to check for allergies prior to administration and continuously monitor the patient for drug sensitivity reactions, including anaphylaxis, throughout every shift. Assess renal and hepatic function before, during, and after a course of treatment, and check to see if monitoring of blood levels is needed to avoid toxicity. Be aware that the drug must be delivered at specific times to ensure appropriate maintenance of levels. When administering any medications, including antibiotics and fluids, the nurse must always check for compatibility prior to administration. Different fluids can be incompatible with each other, and medications can be incompatible with not only other medications, but also with certain fluids. Always check the antibiotic you're about to administer is compatible with fluids already in the line. Also check to make sure that the antibiotic is compatible with any other antibiotics that may have been run through the same secondary line. Never administer an antibiotic at the same time that a registered nurse is giving an IV push medication without checking compatibilities. Although some facilities may have IV compatibility charts posted, often these charts are quickly outdated, so don't rely on them. Contacting a pharmacist directly or utilizing an online resource is much more reliable. There are 3 different types of incompatibilities: physical, therapeutic, and chemical. A physical incompatibility refers to a visible reaction that occurs, such as changes in color, haziness, turbidity, precipitate formation, and gas formation. The most common type of physical incompatibility is precipitate formation. To prevent physical incompatibility, always flush the infusion device with normal saline before and after each medication administration. Never administer a drug that forms a precipitate. A chemical incompatibility involves the degradation of the drug, which may occur for a variety of reasons, such as drug decomposition. In the case of chemical incompatibility, the reaction may not be visible. The most common cause of chemical incompatibility is the reaction between acidic and alkaline drugs or solutions, which results in a pH level that is unstable. Finally, a therapeutic incompatibility is an undesirable effect that occurs in the patient as a result of 2 or more drugs being given concurrently. An increased therapeutic or a decreased therapeutic response is produced. The incompatibility often occurs when 2 antibiotics are being given. For example, with the use of chloramphenicol and penicillin, the chloramphenicol has been reported to block the action of penicillin. Therefore, if prescribed, the penicillin should be administered at least 1 hour before the chloramphenicol to prevent this therapeutic incompatibility. Factors affecting compatibility include order of mixing, drug concentration, contact time, temperature, light, and pH. Check compatibilities via chart, internet, drug books, or even with your pharmacist. Change solutions every 24 hours. Carefully inspect solutions and tubing for cloudiness or crystals and do not infuse if you see those. Select the correct diluent to reconstitute the drug and the correct solution for the infusion. Do not mix drugs that have a special diluent with other drugs. Flush the IV line between incompatible solutions. Secondary tubing is used to administer a piggyback antibiotic. This tubing is shorter than primary tubing and usually has no injection ports. The secondary tubing attaches to the highest injection port of the primary tubing. Aseptic technique must be maintained to prevent contamination. Often the secondary tubing package will contain a plastic hanger. This hanger is used for the primary bag, not the secondary bag. The primary bag must be lower than the secondary bag or the antibiotic bag in order for the antibiotic to flow correctly. Or in other words, the antibiotic must be higher than the primary bag. The bag that is higher will flow, and that is illustrated in this photograph. If you look at this bag right here, that is your secondary bag, and this is your primary bag. Always double check incompatibility before attaching a secondary line. Remember that intermittent tubing must be changed every 24 hours and continuous tubing every 72 to 96 hours. If this secondary tubing becomes disconnected from the primary line, the secondary tubing is considered intermittent even if the primary tubing is continuous. It must stay attached to a continuous primary line in order to also be considered continuous. When one patient is receiving several antibiotics, some facilities require you to use different secondary tubing for each antibiotic. Other facility policies allow for backflushing. Be sure to check your facility policy. When administering an antibiotic and the patient already has a continuous infusion running, here are the steps to follow. Wash your hands, verifying the medication, including expiration date and compatibility. Clamp the secondary tubing, remove the spike cover, and spike the antibiotic bag, being careful not to contaminate the tip. Clean the upper injection port of the primary tubing well with alcohol for a minimum of 30 seconds and be sure to scrub the threads. Attach the secondary tubing. Hold the secondary bag lower than the primary bag. Open the clamp and allow fluid from the primary line to prime the secondary line. This is called backflushing. Reclamp the secondary line temporarily and position the antibiotic higher than the primary bag as illustrated on the slide. Finally, set the flow rate. If you have an electronic infusion device, program the device with the flow rate and the volume to be infused. Open the clamp and make sure it is dripping. If this is to be a gravity drip, open the secondary clamp, then set the flow rate using the clamp on the primary line. Be sure to set a timer so you can come back and reset the flow rate for the primary fluids after the antibiotic has completed. Only a few things are different when administering a piggyback if the IV site has been saline locked. After doing your entry steps, flush the site as described earlier in this presentation, making sure that the IV site is still patent. Prime the primary site and attach. Follow the same steps as we just discussed to prime the secondary tubing and start the flow. Make sure after the antibiotic has completed, you allow enough fluid to flush the primary line from the primary bag that all of the antibiotic reaches the patient. Once completed, detach the tubing, recap, and flush the IV site. For subsequent doses using the same tubing, back flush before spiking the new bag. This will clear out any residual antibiotic from the secondary line prior to attaching the new bag. The scope of practice of a qualified LPN allows the LPN to stop blood or blood components when a complication occurs, and then immediately notify the RN or healthcare provider for further orders. Being able to recognize complication of blood or blood components is very important. Be sure to be aware of signs and symptoms of blood transfusion reactions. Fluid overload can also be a complication of blood or blood components. The INS suggests that assessment and monitoring of IV sites occur at least every 4 hours for alert and oriented adult patients who are receiving non-irritant, non-vesicant infusions. On the other hand, the IV site should be assessed and monitored every 1 to 2 hours for critically ill patients, for adult patients who have cognitive or sensory deficits, or who are receiving sedative medications. The frequent monitoring should also take place when the patient is receiving irritant or vesicant medications and for patients whose IV is in a high-risk position, such as an area of flexion, like the antecubital area. Monitoring of the patient should include assessment of the peripheral IV site and the surrounding area, flow rate, clinical data, patient response, and adherence to prescribed therapy. The nurse should verify that the solution is hanging, that the amount infused is correct, and that the rate is correct. The nurse should assess the IV site, checking for patency, palpating the vein for discomfort, and assessing the site for signs of infection, infiltration, and phlebitis. The dressing should be assessed to make sure it is dry and intact, and the tubing connections checked and lines traced to their origin. Vital signs should be assessed, especially blood pressure, pulse, and temperature. Daily weights and I's and O's should be documented and monitored. Monitor the patient for signs of fluid overload, including edema, jugular vein distension, shortness of breath, and crackles in the lungs. Central lines, including PICCs, need additional monitoring. The nurse should make sure there is no change in the external catheter tip, no patient complaints of bubbling or earache with flushing, no visible chest veins, and no arm swelling. Another authorized procedure is discontinuing a peripheral IV. Potential complications include infection, bleeding, and catheter embolism if part of the tip of the catheter breaks off during removal. First, verify the physician's order for the procedure. Gather the appropriate equipment you will need, such as a 2x2, sterile gauze pads, tape, and clean gloves. Perform entry steps such as verifying patient identifiers, explaining the procedure, and washing your hands. Open the gauze packages and prepare a strip of tape. Turn off the infusion and don your gloves. Loosen the dressing and tape with one hand while stabilizing the cannula with the other hand. While continuing to stabilize the cannula so it does not rip out, remove all of the tape and dressing. Hold a sterile gauze over the site without applying any pressure. Remove the catheter carefully and smoothly, keeping it almost flush with the skin. Do not put pressure on the cannula while it is still in the vein. Pressure on the catheter can cause injury to the vein or rupture of the cannula. After the cannula is out of the skin, immediately press the 2x2 gauze over the site. Continue to apply firm pressure until the bleeding stops. If the patient is on anticoagulant therapy, pressure may need to be maintained for 5 to 10 minutes or longer. When bleeding has stopped, replace the gauze with a clean gauze, pad, and tape in place only after you have cleaned the site with alcohol and scrubbed for a minimum of 15 seconds. Observe venipuncture site for redness, swelling, drainage, or hematoma. Inspect the tip of the cannula to make sure it is still intact, and then dispose of equipment and gloves properly and wash your hands. Document where the IV was discontinued from, the appearance of the site, how the patient tolerated the procedure, and whether the cannula tip was intact. Check the site again in 15 minutes to ensure that bleeding has stopped. Finally, depending on facility preference, topical analgesic creams and patches may be used prior to venipuncture as long as there is a physician's order and a policy. Although transdermal creams are effective, the disadvantage is the time duration until an anesthetic effect can be up to an hour. Make sure to assess for allergies to lidocaine prior to administering the cream. Always don gloves before administration to prevent absorbing the medication yourself. After applying the cream, place a transparent dressing over the cream. Leave the dressing in place for the recommended time period, usually 30 to 60 minutes. Remove the occlusive dressing and remove the cream by wiping the clean gauze. This concludes Unit 6 of the IV therapy course.